Another accessibility would be parking space for the wheelchair accessible. Universal designs would be your wheelchair ramps, your doorways, your hallways. They have to be a certain width, and your toilets are supposed to be a certain height. Your door handles, they're supposed to be a lever, not a doorknob, so that someone in a wheelchair can actually pull. So there's universal things that after the ADA is adopted for other people, for businesses to know about. Parking, there should always be a place that they can park for close access to the building. The walkways should be free and clear and also non-slippery. The entrance should be 32 inches wide. And the sidewalks need to be 3 feet wide. There's just certain specifications now when you're building new that you have to go by code. The doors, as far as the door handles, that would pertain to the door and a certain width. The reception area, you should always have chairs that are a little bit higher for those that are in walkers or on crutches, that they don't have to, especially, you know, if the older people, if they're all the way down, or someone with a disability and they're trying to have to get themselves up, if you had something a little bit higher that they can sit on, then that would help them as far as, and also to make sure that they have a place to sit, so they're not sitting in the middle of the room all by themselves, you know, fish in a fishbowl. The treatment room, to make sure that it's wheelchair accessible, so everything's free and clear, that they can get through all right. And the bathrooms too. The bathrooms should have the higher toilets and they should have handrails. So your initial appointment, in private practice, in some offices, the initial appointment is actually seen with the dentist. And sometimes the initial appointment with a new patient, especially a patient with a disability, might just be to see if they feel comfortable in the office. You might not do any work at all. It might just be a time that they can look around, they can they can meet people, they can come in and just sit down and talk about maybe what's going on with their mouth. At that initial appointment, the one thing that they really should do is actually do a plaque-free score, let them see the disclosing, start to give them a little bit of patient education about what they can do at home. And that might be all that you do in that initial appointment. But it's all about their comfort. It's all about how much they can tolerate for the day. So they're just gonna come and get oriented to the office. And a communication. So you're gonna have an open communication with them, you're gonna listen to them, you're going to talk to their caregiver or themselves, whichever one. And you're going to make sure that in that communication, when you're showing them, there was a saying that I used to have on my kids' wall. It was a Confucius saying, tell me and I will forget, show me and I will remember, involve me and I will understand. And so that's why we tell you all the time to the show, tell, do. And so when they have a disclosing solution on, and this is like a hint because nobody wants 5 pints off for biofilm removal, right? When you're in clinic, okay. So after you do the plaque-free score, that's the best time to give patient education because they've got it all over their teeth. So hand them the toothbrush, show me how you brush your teeth. And guess what? They're showing you, they can see how they're removing the plaque as they're showing you or not removing the plaque. Then you can tell them and show them again how to do it and then have them repeat it. And so they become involved. And not only that, but look at all the biofilm that you've removed and you don't have to worry about getting 5 points off for each place of biofilm. That's your preventive care instructions that you want to do. It's so quiet in here. I don't hear that little thud noise anymore. Listen to you hear it. Okay, so it's not like a factory. You're not going to be running people in and out, and you're going to have people with canes, crutches, and walkers coming in. They're going to walk a little bit slower. So again, when you have them, they come into your chair, you're going to make sure that you're going to lift that chair up a little bit high so they don't have to actually sit all the way down. And then you can lower a little bit and they can swing their legs over. With the patient positioning, once they get their legs all situated, you might actually have to put a pillow underneath their knees as you're laying them back. You want to always make sure that you're laying that chair back very slowly. For someone with a swallowing defect, You wanna make sure that you don't put the chair back all the way. So you wanna make sure that it's semi-reclined, and you might have to stand up and practice down hygiene. So you're gonna tip the chair back slowly. And this might be for someone who has a back problem. They might have to let those muscles kind of, slowly work into that reclining position. You might have to put pillows underneath their legs or in the small of their back, just to make them comfortable. And then again, you wanna make sure that when you're ejecting them out of the chair, you do it slowly, so that the blood can go back down to their feet and they can not have so much of a vertigo. And for body stabilization, for a small child or for someone that is moving quite a bit, you might have to use what's called a pita wrap, or you can use a papoose. We did that right when I got my license. While I was waiting for my license, actually, I worked in a pedodontist's office, and we had to use a papoose, and I'll show you a picture of what it looks like. Do you guys know what a papoose looks like? No. You want to stabilize the patient, and just for their safety as well as yours, because you want them grabbing and while you have sharp instruments in your hand. But a papoose board, actually, they recline on the papoose board, and you secure their ankles with Velcro, you secure their wrists, and then they're wrapped like a papoose, like you're swaddling them. And for head stabilization, for someone who is moving quite a bit, even like with cerebral palsy, you might have to just wrap your arm around their head just for stabilization. I mean, not in a headlight, their neck, but, just wrap it around their head so that you can stabilize their head while you're working. And then this is a picture of a papoose board. So, and it comes in pretty pink colors now too. And it's got, cushions. Pardon?
So it's traumatizing.
Well,
But
they're safe.
The nervous system, that's supposed to relax you too.
That's
Pressure.
Sure. So now your oral manifestations that you may see because of a disability, congenital, that actually could be your cleft palate. I found this picture of the cleft palate. This is an older person. How old is this person? Can you see that they have their permanent teeth? So they are at least 12, because they've got their, I can't tell if it's a 6-year molar and a 12-year molar, but I thought, oh, how sad to go through life with not having that actually repaired. An injury, they could have been in a car accident, and that could have injured them and actually given them maybe a disability because of the car accident. Paralysis, if they had a stroke, or if maybe Bell's palsy, so they have a little bit of paralysis on one side of the face. And malocclusion, they could have, because of the disability, they could either have too many teeth, not enough teeth. The jaws could actually be malaligned. And all of these actually would probably contribute to maybe an increase in biofilm, because they're not able to control it as much at home, which means that you might have to see them a little bit more often. Therapy-related oral findings would include, this is someone who's on phenytoin, and that is actually Dilantin. And so you usually have to see these patients more often. When the gingival tissues, when they actually are, crush you. When the gingival tissues are, I'm sorry, I just lost the word. When they're overgrown and they're actually starting to interfere with a chewing ability, then they usually have to have a gingivectomy, but that's not because they're on Dilantin all the time. Then that means that they might have to have it more than once, or there are some patients every 6 to 9 months might need a gingivectomy just because the tissue grows that quickly. That's not painful, actually.
The gingivectomy isn't?
The gingivectomy is, No, yeah, could be painful. It's very uncomfortable.
That's odd.
But as far as, that's not painful unless it's actually overgrown and they're actually chewing on the tissue, then it's painful to the patient because they can't masticate. This is radiation or chemotherapy, and you can see that the root carries. So when someone's having chemotherapy, they're having radiation of actually the head and neck. It's destroying the salivary glands, which leads to xerostonia. So that would be another reason to have the patient come in more often, and then you're going to recommend fluoride treatments, fluoride dentifrices. This tissue, you can see in this area, it just looks painful because it's sloughing, and this is all reddened because it's already sloughed there. So some of the things that you might have to do is actually just very gingerly do a biofilm removal, very little calculus debridement, just because you want you don't want to really disturb that tissue so much. Most of the time, we don't see anyone who's been being treated for cancer, especially if they've had chemotherapy or radiation therapy, unless we've got an okay from their doctor, or sometimes even 6 months after the treatment. So we're all about disease prevention. That's why we're in this business. And the first thing is the biofilm control, because we know that if there's less inflammation in the mouth, then there's less inflammation throughout the rest of the body. And if the body's trying to work on other infections, we want to make sure that it's not concentrating with infections that may be going on in the mouth also. We want to make sure that we recommend fluoride rinses if they can rinse, fluoride dentifrices, in-office fluoride treatments, and we do have prescription take-home toothpaste. Prevident 5000 is really concentrated fluoride toothpaste. The PFS does not stand for plaque-free score in this instance. It actually stands for Pitt and Fisher sealants. So anytime that someone has a lot of biofilm, we want to make sure that we can give them anything for prevention, and that is if they are able to have Pitt and Fisher sealants, we want to make sure we do that for them. And then their diet. Most people that are on a disability or have a disability, they might have a soft diet, or like we talked about, the treats, they might always get the candy treats, and so they might have a little bit more rampant caries. So then we need to talk to the caregivers, involve them in the care of that person. And we might have to modify when they're brushing. We have electric toothbrushes, which is great. We can recommend those. Some people can't stand the vibration in their mouth. So if we have to get away from that part of it, then we're going to actually try and modify their toothbrush. So this is taking a piece of Velcro and actually and wrapping it around the hand to hold the toothbrush. They might not be able to grasp it, but at least somehow they can get some type of motion. And some people that don't have control of their hands, they might have to move their head with a toothbrush just so they can get that plaque control. And again, we're trying to make them as independent as possible. And these are other techniques that you can do. I talked about the tennis ball with the elderly patient, same thing. That's a handlebar. You can get handlebars for $2 for $1, and then we can fill them actually with a resin type material and put the toothbrush in and let it harden so they have something to grasp onto. Or they actually sell them like this. They actually sell the toothbrush like that. I did see some at Midwinter. I should pick some up. I was showing you guys. It was crazy busy there, wasn't it? This is actually for a patient who's gone through radiation therapy or chemotherapy, or somebody who's in the hospital, and they actually have sponges. Some of these sponges on a stick, it almost looks like a lollipop, but it's not. The sponge actually can contain some type of either a lubricant or some type of a dentifrice that can help clean. And it's soft on the tissues. And our instrumentation. So are there any questions so far? Am I going too fast? No? So we want to think about our instrumentation. We want to prepare to make sure that we have everything that we need before we get started, because that patient might not be able to tolerate the time in the chair, so we don't want to keep up and going, oh, I forgot to get the Kaptron ready. Oh, I forgot to go get this. I'll be right back. So we want to make sure that before they actually get in our chair, we are totally prepared for them. And then stabilization. So we want to make sure that they're stable and we're stable for their safety and our safety. Now, something for someone who happens to need a bite block, either they can't open, they don't have the muscle strength to open all the way, or maybe they need something to rest on, they do make 5 blocks with a saliva ejector in it, so then you don't have to worry about suctioning. And as far as our treatment, so how are we gonna treat this patient?